Okay.
Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome today's speaker with great honor, none other than Dr. Vinay Kumar Dandania, sir. And let me share some of the achievement of sir. Sir is senior diabetologist as Santivita Hospital, Ranchi, national faculty in RSSDI, Diabetes India, CSI, CD, Dietitian, and IdeaCon. And today, sir is going to discuss on a very important topic, that is role of telemedicine and digital health tools in diabetes care. So to know more about this topic, I would like to invite sir and hand over this session to sir. Sir, over to you, sir. Kindly proceed from here.
Thank you. Good evening. And thank you very much for that very kind introduction. I'm going to share few of the important guidelines on telemedicine. It's a very important topic today. And this is basically a guideline which has been given by the Government of Governors from Medical Council of India, 25th of March 2020. And it's basically telemedicine practice guidelines 2020 is basically to enable RMPs, that is registered medical practitioners, to provide healthcare using telemedicine. So what are the points we are going to discuss is definitions, telemedicine, telehealth, RMP, scope of telemedicine, applications of telemedicine, technology used, mode of communications, guidelines for telemedicine in India, and teleconsultation process, first consultation, and what is follow-up consult. So e-consult is an integral component. Patients collect or receives data or has a non-urgent problem with health, vital signs, lab values, medications, etc. So here the important term to notice is non-urgent problem. It makes an online payment fees to the doctor and transmits the consult, and physicians render advice in a predefined time and transmits the advice. So important definitions are telemedicine, which is delivery of healthcare services using information and communications technologies for exchange of valid information on the following topics: diagnosis, treatment and prevention of disease and injuries, research and evaluation, education of healthcare providers, and the aim is advancing the health of individuals and communities. Telehealth is basically delivery and facilitation of health and health related services by telecommunication and digital communication technologies. The services include medical care, medical provider and patient education, health information services, and self care. The registered medical practitioner is a person enrolled in the state medical register or the Indian medical register under the Indian Medical Council Act 1956, IMC Act 1956. The background is in India, in person health care is challenging due to large geographical distances, limited resources, and result of mainstreaming telemedicine in health system, minimize inequity and barriers to access, reduce the burden on secondary hospitals. And to date, concerns on practice of telemedicine is lack of clear guidelines has led to significant ambiguity in RMPs, gaps in legislation and ambiguity of rules present a risk for doctors and their patients. So, what are the benefits of telemedicine? It's like timely access to appropriate interventions, saving of cost and effort, reduce the inconvenience impact to family and caregivers, can improve patient adherence, and can enable availability of vital parameters through medical devices, maintenance of records and documentation, thus increasing legal protection of both parties. The purpose is basically to give practical advice to doctors and encourage them to consider the use of telemedicine as a part of normal practice, assist RMPs in providing effective and safe medical care, and help RMPs realize the full potential of technology for healthcare delivery, and provide information on various aspects of telemedicine. The guidelines should be used in conjunction with other clinical standards, protocols, policies, and procedures. The scope is that the published under the IMC Act and are of privileged access only. RMPs under the IMC Act 1956. It enables RMPs to effectively leverage telemedicine to enhance healthcare services and access to all, and cover norms and standards of the RMPs to consult patients via telemedicine. So telemedicine, all channels of communication with the patient that leverage information, technology platforms including voice, audio, text, and digital data exchange. So all these things are very, very important in using this telemedicine. The guidelines exclude the following, which is also very important to understand: specifications for hardware or software, infrastructure building and maintenance, data management system involved, standards and interoperability, use of digital technology to conduct surgical or invasive procedures remotely. So this is again a very important area to understand. Other aspects of telehealth like research and evaluation or continuing education of healthcare workers, and it does not provide for consultation outside the jurisdiction of India. Telemedication applications are suitable telemedicine tools available for carrying our technology-based patient consultation, available chat platforms, and available digital platforms. These are few of them on telephone, video, devices, WhatsApp, Facebook Messenger, Skype, or emails. The core principles of telemedicine practice remains the same regardless of the tools or communications used. So the classification of telemedicine applications is classified into four basic types: mode of communication, timing of information transmitted, purpose of consultation, and individuals involved like patients to RMP, caregiver to RMP, RMP to RMP, or healthcare worker to RMP. The mode of communications could be through video, audio, or text based, telemedicine chat based applications, general messaging, text plan, or chat platforms, or it could be asynchronous through email or fax, etc. Timing of information transmitted can be real time video, audio, text, or interaction for exchange of relevant information for diagnosis, medication, and health education and counseling. And it could be asynchronous exchange of relevant information in the form of transmission of summary of patient complaints and supplementary data between stakeholders, and data can be forwarded to different parties and accessed when required. And the purpose of consultation for non-emergency consults: first consult with any RMP for diagnosis, treatment, health education, and counseling, and follow-up consults with same RMP for ongoing treatment with the same RMP who prescribed the treatment in an earlier in-person consult. And when alternative care is not available, emergency cases, the patient advised for an in-person interaction with an RMP. So these are few important things to understand. Technology used and mode of communication, the strength and limitation of various modes of communication. The strength of video is that it's real-time interaction, closer to in-person consult, and easy patient identification, visual cues, and inspection is possible. Like we can see some wound or some allergy rashes, something like that in videos. Audio, it could be convenient and fast, real-time interaction, unlimited reach, no separate infrastructure required, and privacy is ensured. Text-based could be convenient and quick, real-time interaction, easy documentation and identification, suitable for urgent cases or follow-up, second opinions, no separate infrastructure required. And asynchronous could be convenient and easy documentation, no specific app or download requirement. Images, data, reports steadily shared, like in emails, you can send all the attachments. Useful when accompanied with test reports and follow-up and second opinions. The limitations of video are dependent on high quality internet connections at both ends. Privacy is challenged, and audio is not suitable for conditions that need a visual examination or physical touch. Difficult to identify real patients. Text-based could be missing visual and physical touch and verbal cues. Difficult to establish rapport with the patients, and identification of doctor or patient may still be a challenge. Asynchronous is not a real-time interaction, just one-way context, and patient identification is difficult. High latency, chances of missing non-verbal cues. So the guidelines for telemedicine medicine in India, there are the seven elements which are very important to be considered before any telemedicine consultation. First is the context. The RMP should consider the following: whether telemedicine or in-person consultation is appropriate for the patient, choose the appropriate mode, technologies available, and their adequacy for a diagnosis, complexity of patient's health condition is also important, same standard of care as in an in-person consultation, but within the intrinsic limits of telemedicine. Two is identification of RMP and patients. Both patient and the RMP need to know each other's identity. The RMP should explicitly ask the age of the patient, and if in doubt, you can ask for the age proof. Minor must consult along with an identified adult. The RMP should inform the patient about his/her name and qualification, and every RMP shall display the registration number on prescription, website, electronic communication, and receipts. The other is the mode of communication. Various technologies are available to deliver telemedicine consultation. Primary three modes available are video, audio, or text, which we discussed, and the strength, limitation, and appropriateness need to be considered by the RMP. Situations may demand real time consultation, voice interaction, or video consultation. And the patient consent is also very, very important. The patient consent is essential for any telemedicine consultation. Implied consent if the patient initiates the telemedicine consultation. Explicit consent required if health worker, RMP, or caregiver initiates a telemedicine consultation. The RMP can record an explicit consent in any form. The next is the patient evaluation. Gather sufficient patient information about the patient condition before making any professional judgment. Supplement information through conversation with a healthcare worker or by any information supported by technology based tools. Request for additional information from the patient. If RMP feels that the information received is inadequate, mention maintain all patient records, including case history, investigation reports, images, etc., as appropriate. If you're using an electronic medical record system, this can be very well achieved. The different types of consultation could be criteria for first consult. When the patient is consulting with the RMP for the first time or more than 6 months have lapsed since the previous consultation, or if earlier consultation was for a different health condition. The criteria for follow-up consult is the patient is consulting with the same RMP within 6 months of an in-person consultation for continuation of care for the same health condition, and not a follow-up if there are new symptoms unrelated to the same health condition and or if RMP does not recall the context of previous consultation. The last one is the patient management, health education, counseling, prescribing medicines are very, very important, and the prescribing medications via telemedicine, same professional accountability as in traditional in-person consult. Only when adequate and relevant information is gathered, prescribed medicines are in the best interest of the patient, and prescribing medicines without an appropriate diagnosis or provisional diagnosis will amount to a professional misconduct. So prescribing medicine, the specific restrictions are: list 0 is safe to be prescribed through any mode of teleconsultation, used for common conditions and are often available over the counter like paracetamol, ORS solutions, cough lozenges, etc. Deemed necessary during public health emergencies like we had in COVID time. List A can be prescribed during the first consult, like video consult, re-prescribed for refill in case of follow-up, relatively safe, low potential for abuse. And list B can be prescribed in follow-up consultation in addition to medications prescribed during in-person consult for the same medical condition. And the prohibited list is cannot be prescribed in telemedicine due to high potential of abuse. Medicines listed in Schedule X of Drugs and Cosmetic Act and Rules, like drugs like tramadol or drugs like alprazolam and other drugs, and any narcotic and psychotropic substance listed should be avoided in the which are listed in the Psychotropic Substance Act 1985. Prescriptions as per the Indian Medical Council regulations should not contravene the provisions of the Drugs and the Cosmetic Acts and Rules. Provide photo, scan, digital copy of a signed prescription or an e-prescription to the patient by email or any messaging platform. In case prescriptions is sent directly to the polypharmacy or to a pharmacy, RMP must ensure explicit consent of the patient that entitles him or her to get the medicines dispensed from any pharmacy of his or her choice. Fees for telemedicine consultation treated the same way as in-person consultation from a fee perspective. The RMP may charge an appropriate fee for the telemedicine consultation provided, and an RMP should also give a receipt invoice for the fee charged for providing telemedicine-based consultation. This is the type of sample prescription that can be shared to the patient after the consultation. The teleconsultation process, the first consult is like video, audio, or text, patient identification, consent, and quickly assess if emergency care is required. If yes, advise first aid, immediate relief measures, and guide patient for referral as appropriate. If there is no emergency, then take a detailed patient evaluation, obtain maximum complete patient information, history, investigation reports, past records, ask for additional info if required. RMP may switch mode of communication if required. In the case appropriate for telemedicine, yes, management, health education, counseling in a specific treatment, and if no, health education refer for in-person consultation. So this is how you can actually follow the process of teleconsultation. At any stage, the patient or the RMP can choose to discontinue the teleconsultation, and at any step, the RMP may ask the patient for another consultation. At any stage, the RMP may refer or request for an inpatient consultation. Who should take teleconsult? Diabetics who are on insulin who needs adjustment or titration, gestational diabetic mellitus, patients who are on CGM, and diabetics on insulin pump, thyroid patients, endocrine patients to send reports after few days of consult or scanned reports. If a consult comes after 3 months, polite reminder for actual consult with appointment. Not for all, not a substitute to actual consult at clinic, but supplementary to first consultation. Are you afraid of seeing less patient in your waiting room? No need to worry, it will not happen. It is a virtual consultation. Be the first to embrace the technology to cater to diversity of patients. What are the benefits? Patient satisfaction, better care and better endpoints, saves time and money to patients, brings in more revenue, increases your efficiency, saves your time and effort, outstation, abroad patients, e-consult patient or doctor anywhere in the world, access to email, iPad, iPhone, Wi-Fi even in airport. Physician's benefit is digitization of clinic with CCTV, access patient record line, e-consult with patient, safe prescribing, laboratory orders and reports, secure messaging, analytics, and access medical record online is the patient benefit, e-consult with physicians, goals and progress management, alert and reminders using secure data uploads, diet and lifestyle management, secure and easy second opinions, and visit summaries. So there are benefits to both the patients and the physicians. So to summarize, tele e-consult, supplementary to actual consult, improves clinical efficiency, revenue, patient loyalty to doctor strengthens, and patient avoids shopping around. Patient feels that doctor is a click away from me, and this is going to help access of diabetes care in our country. So another important tool which is important in your clinic, the digital tool, is electronic medical record, which is called by the term EMR. If you see the case one, how you intensify therapy in an existing patient with an A1C of 9.6 and a recent history of MI, assuming that he has come to you without his previous medical record. Secondly, I would like to conduct a study among type 2 diabetic patients on insulin with CKD above the age of 70 years. So if you have data of 1,000 patients, you can do that. Thirdly, this patient under your treatment for 5 years has lost all his previous records and is requesting for a copy of his lab investigation since his first visit for reimbursement purposes. Again, your hospital is used to keeping all the proper paper records of your patients. However, in a natural calamity, all of them get completely destroyed. So these are few scenarios where your electronic health record versus electronic medical record is important. So EMR is used with a single practice while EHR is used across multiple offices and practices. This is how you differentiate between the two. And if you see the different components, the patient management component, the clinical component, the laboratory component, the radiology information system, and the billing system, this is what is EHR. Patient management component is equipped for patient registration, admission, transfer, and discharge. And patient registration includes key patient information such as demographics, insurance purposes, contact information, etc. And clinical component includes computerized provider order entry, electronic documentation, nursing component, etc. And if you see, the computerized provider order entry allows to enter orders that are needed for patient management, and clinical decision supports tools and drug allergy and drug diagnosis interactions. The clinical component is again important in the sense that electronic documentation is there. Document notes such as history, physical, consult, discharge summaries, operative notes, etc. And the pharmacy system for maintaining a drug formulary, filling prescriptions, and cross-checking any orders. The nursing component for collection of key patient informations. So this is how it actually moves on the physician office. Physician orders test, physician reviews results, and physician shares results and the treatment. And again, if you see, the laboratory interventions are there, the orders are routed to respective labs. Results, returns are directly available in the physician's EHR. So pathology labs, hospital labs, radiology, hospital intervention examinations, public health portal, patient portal, and other providers, they all come to your physician's office. Radiology information system is again used to manage patient workflow, ordering process, results, and the image themselves. Billing system is again incorporated, is used to capture all charges generated in the process of taking care of patients. These charges generate claims which is submitted to insurance companies also. Patient interface of EMR, patient portal view patient history, treatment, and medication, can check on records or additional notes. Like our clinics, which we use the software, patient can access their records. Scheduling is software can direct patients to log into their accounts and schedule appointments. What are the advantages? It improves diagnosis and treatment, significantly fewer errors found within personal health records, faster care and decision making responses, production of legible records, reduces many problems of wrong prescription, doses, and procedures. Adverse drug reactions can be reduced substantially when the EHRs are connected to drug banks and pharmacies, and easy accessibility from anywhere at any given time, require less storage space and can be stored indefinitely. And it facilitates quick data transfer, improve healthcare quality, enhances safety and efficiency, reduces number of lost records, help research activities, allow for a complete set of backup records at low cost, and improve patient compliance, facilitate quality assurance, and reduces medical errors, cost savings at the system levels of chronic disease prevention and management. We also have an advantage at the EMR. When you prescribe a medicine, you can write the generic version of the medicine, and the patient can purchase according to the availability of those molecules. MCR recommendation, if you see, keep records for 3 years from the date of the commencement of the treatment. If demanded, issue in 72 hours. Maintain a register of medical certificates giving full details of certificate issued, and effort shall be made to computerize medical records for quick retrieval. Short-term cost benefits, if you see that there is a reduced employee time spent on filling, retrieving, and organizing physical charts and documentation. It reduces amounts of physical space used to store, and the time saved with information exchange between medical professionals and insurance companies. At the same time, if we are talking about telemedicines, patients who have an EMR record because of physical consultation, it's very easy to have a teleconsultation when they need it. Long-term cost benefits are significantly reduced risk of data breach and HIPAA violations. Transferring large amounts of data is simpler and faster when changing locations. Less physical papers are needed, along with the reduced necessity of paper products, and easier to adopt new regulations in the future with a technologically appropriate system. Handwritten charts can be difficult to comprehend by future healthcare providers, making EHRs much more efficient for future users. The barriers is cost, insufficient scientific evidences, not useful in certain populations, data protection, data security, and regulatory barriers, boredom, and many a time nuisance as well. So to summarize, the digital EMR is a valuable tool for both clinical and research application. The DEMR system can help in standardizing various procedures, and has enhanced the quality assurance program. A strategy focused on financial support, multiple networking, and training of technical support staff may be necessary to promote broader adoption of the DEMR system by medical service providers in India and other developing countries. So I thank you all for your patient listening. There are few questions which are unanswered with EMR because we don't know whether we are improving the process of care. So using EMR is like riding a horse. New rider is afraid, learner falls many times, and experienced enjoy the ride and remains ahead in the race. Thank you all for your patient listening, and I thank the organizers once again for giving us this platform, a very important platform, digital platform for interacting with all of you. Thank you very much.
Thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants who have joined this session, sir. Sir, I can see, sir, we have some question. Without any further, shall we take these questions?
Yeah, we can.
Yeah, the first question is from Dr. Subramaniam. He is asking how can digital health tools to be tailored for a specific patient population, such as the elderly or those with limited technological literacy. Sir, what's your point of view on that?
This is a very interesting question, and we have been actually following this in clinical practice. We have two extremes of patients: type 1 diabetic patients who are having a age less than 18 years of age, and we have even a lot of elderly patients who are also actually beyond something like 60, 65 years of age. And both of them are very, very comfortable with both telemedicine and electronic medical record system. The only thing is, when you are actually having a first physical contact with these patients, you can actually share with them how they can go for future follow-up advice through telemedicine and teleconsultation. At the same time, how they can actually access their electronic health records when they want to, because they get a link on their mobile phone whenever they have a physical consultation, and that can help in getting their records. The important thing is you need to tell them what you are doing in your clinical practice and what is your record system in your clinical practice and how they can actually get 100% out of it. That is how they actually learn to use it. People from rural areas, believe the rural population which we are talking about. I work in Jharkhand, and Jharkhand has two-third rural population and one-third is only urban population. But believe me, the rural population, there is fast urbanization. Almost everyone is carrying a mobile phone. Everyone is carrying a 5G or 4G on their mobile phone. Everyone has got a motorcycle and a car these days, and everyone has got a television and a Tata Sky and Airtel, whatever you name them. The only thing is, we need to tell them you are having a benefit of digital consultation in your clinic. Only then they will have an access. If you don't share with them the benefits of telemedicine and teleconsultation, which you are actually going to provide them, they will not access to the benefits. So it's very important that we need to share with them that this is what benefit you have in my clinic, and next consultation, if you need any time, you can share with us. This is important. I've seen in diabetic foot clinic for patients who have come to our clinic. Now they click their pictures, follow-up pictures, and they share in the through WhatsApp or through emails. It becomes very easy to see whether they have a bad foot, an infected foot, or the wound is improving through granulation tissue. So we can tell them you need not come to my clinic, do an alternate date dressing, continue with the medicine, and if needed, we can ask for a swab, pus culture swab. If the sensitivity is positive, we prescribe them antibiotics. So this is how the elderly population are also following up. So I'm sure we need to actually take the importance of these facilities today, and we need to educate our patients, give them little bit of 2 minutes that this is the advantage of you being coming to my clinic.
Thank you so much, sir, for sharing your point of view on that question. I hope that it will be received to all the participants. Moving forward, sir, we have another question, sir, from Dr. Agnihotri, and she is asking how can telemedicine address gaps in diabetes care for patient in rural and under-reserved areas?
Thank you, Madam Dr. Agnatri, for this excellent question again. And believe me, this is the gap which we are going to fill. That is the basic advantage of teleconsultation. I'll tell you, if I'm sitting in a place called Ranchi, which is a tier 3 city, and I have to take an opinion from a super specialist sitting at Kokila Ben Hospital in Mumbai, I can do that very, very easily. Same, a patient sitting in a rural area, even they have access to telemedicine and they can consult someone in a city like Ranchi or someone sitting in Bombay. The only thing is they need to know that there is something called as telemedicine, and that can be only achieved by educating the registered medical practitioners in the rural areas. And if the registered medical practitioners in the rural areas are educated regarding the facilities which are available today, all the patients can have this access. The important thing is we are not having a good chain of communication with the registered medical practitioners in the rural areas, and at the same time the number of registered medical practitioners who are there in the rural areas are also pretty less. So we need to create resources in the urban population and rural population as well, and this is what we are doing through these educational programs, and we are trying to access these people in the rural areas. And through the registered medical practitioners, this patient can have the benefits of teleconsultation. They cannot actually have an access directly to your clinic or directly to your hospital. Faraz, I think you lost your link.
Thank you so much, sir, for answering this question, sir. I hope, sir, you are able to clear all the doubts of the participant, as I can see no more question from the participant, sir. It was really nice to have you in our platform, sir. Sir, as there is no more question, with all your permission, shall we conclude this session for today?
Yeah, thank you. Thank you, Faraz, for being here.
Welcome, sir. Yeah, and we
Thank
would
you.
like to see you in future also with different topics, sir. Till then, take care of yourself. It was really nice to have you, sir. Have a great. Thank you so much, sir.
Bye.
Bye, sir. Take care.